I would like to go to the next sponsored lecture. And so this is sponsored by 3M. I really appreciate 3M for the sponsor for this lecture. And the speaker is Ken Loy. As many of you know that he is one of the leading surgeon in this chapter. And as in my presidential address, he's very fond of his puppy. And he's a very skillful surgeon. And he's also pay attention to the ELAS during the COVID time. So that he will talk about ELAS and the bariatric surgery during COVID time in this lecture. So would you start your lecture, Ken?
Thank you. Good evening. Hopefully you're enjoying the APC IFSO program currently that we put together for you. My talk is sponsored by 3M in the plenary sessions, and the topic that I'm going to talk about is try to keep everything together for our Asian Pacific colleague on COVID, ERAS, and bariatric surgery. Just a little bit on my personal experience. Hopefully, you can either dispute, enjoy, or probably take it home. My disclosure, including that I do talks and consultancy for different company, and we're very grateful that 3M actually sponsoring the sessions, because I think as a surgeons mostly what we're dealing with is company that providing our surgical gear for stapling and or sealing device or etc. But 3M is probably what we're famous about is mask. But when you dig deeper, it's actually something that we may be able to help us surgery in the future. So I guess I wish this is the last talk that we give virtually, and the next year that we can all come together and either celebrate or commiserate what we've been going through for the last few years. And certainly, if you look at what's been happening in the world from BJS publications, I think different countries are hit by COVID in terms of different waves and forms. And currently, I understand Europe is the fourth wave, and in Australia is the second wave, and in Asian Pacific, a lot of countries start opening, but we don't know what's going to happen next year. But we can always draw on the experience, and the estimation or the task force that they put together is that during the time of lockdown from COVID, we lost a lot of time to operate on our elective patients, that including cancers, bariatrics, or even obstetric patients. I guess cancer surgery has always been prioritized, and the slowdown seems to be possibly around 35%. But a lot of the benign surgery, including colorectal surgery, orthopedics, and upper GI surgery, are almost up to 80% of the elective surgery are being postponed to channel resources to deal with COVID, including even obstetric or gynecological procedure. And it might not sound impressive, but when you add together on the numbers on different continents of what surgery being delayed, is quite a massive numbers that we have to deal with or catch up afterwards. Especially I think in European, Asian Pacific, and North American, which has good track record on what or how many type of surgery being done each time. The numbers are quite daunting, and the question mark is, are we ever going to catch up with them, or should we devise some sort of strategies to make sure that when a pandemic is over, we can work faster, we can work safer, we can work more efficiently. And I'm sure my friends later on will that we have another sessions to talk about different continents and draw on the expert opinion on how they deal with the restart of bariatric surgery. In America, it was estimated that with this shutdown and the coronavirus, in the optimistic case, there is wiping out at least $53 billion of revenue from private hospital. And if we're pessimistic about it, they probably lost about 122 billion and leading to a lot of hospital really close down, sacking staff, or even stop functioning. I guess also how quickly we back up and running. It really depending on how quickly different countries rolled out the policy, the politics on the vaccine, and even come down towards the leadership, whether they experience or whether they actually believe in the virus and how they're going to balance the economy versus the healthcare. And if we open up rapidly, then there will be life being lost. And if the virus are not, and we're not immunizing enough people, then also we cannot carry out day-to-day function of surgery. Or patient have surgery will get really sick and die from it unrelatedly to surgical costs. And if you survey the CFO on how they're going to do after their opening, I think what they wanted to do is, in fact, very sensibly, they really don't want to sack staff or entrench people or thinning out the workforce to reduce the amount of spending. But what they want to do is to improve clinical outcome. And what they want to do is also try to basically, I think, deferring a lot of the capital investment. And hence, I think the economy was to save money in terms of try to survive. But in fact, I think if you look at outcome for surgery, a lot of them depending a lot from what we're using and how our strategy is. And hence, I think we should utilize something called a ERAS, which is not widely implemented and sometimes very difficult to understand. I hope to try to make it simple if we can. And I think the way that to convince our administrator, our government, or our health ministry to spend money is the fact that I think going forward after the pandemic, when our team just published an article in Source Journal looking at the role of bariatric surgery as a public health measures combating the COVID, because during the lockdown and the COVID, we learned the fact that I think the patients that are dying are the one with comorbidity and often patients are obese. So going forward in terms of further reducing the number of deaths from COVID or even other diseases and such as cancer, etc., bariatric surgery is something that we should advocate for. And I'm sure you all know that the amount of bariatric patients that we're operating on, the patient that who are clinically obese are still sitting around 1 or 2% of patients. So I think as a whole of bariatric community, we had our rooms, we had our role, and we have our job to actually convince patients and other people that this is a worthwhile surgery and this is a surgery that we're going to spend to actually reduce the amount of public health spending. The key point that we raise in our article is that both basically COVID channel resources, obesity also do, and the importance on bariatric surgery in terms of prevention of the complication related. And also during the pandemic time, I think there are a lot of people being locked down, and in fact, it's actually we're living in a pseudo-obesogenic environment, which leading towards us being to deal with that afterwards. And I think we should prioritize that afterwards, but on who and how and what. And I think, in fact, that I think we need to work smarter in terms of assessing our bariatric patients. We do a lot of adaptations during the time of lockdown in terms of telehealth and also in terms of assessment of surgery and also follow up on patients. Those probably can be used as a long-term strategy as well. So I think one of the strategy that I think make a huge difference that we've been in fact doing before the lockdown was ERAS. So that originally originating from Denmark, actually applying more a lot to open colorectal surgery. So I'm going to draw a lot of reference from our colorectal colleague because their surgery is slightly different than us, although they are also now mostly minimal invasive. But they come to a state that they've been dealing with a lot of contaminated field and also a lot of major long surgery that is really we can use it as a way to actually learn from it. In fact, I think what they do for surgery is again also application is quite wide. Even orthopedic operations and other vascular surgery are using it. Is the fact that I think we can assess the patients in different way to enhance the patient's operations and to reduce the complications. But different specialty will utilize different way, particularly for their own surgery. So that's why it's making it more complicated. And it not only requiring on surgeons, but it require on convincing of the whole team in terms of anesthetic and our practice nurse, our nurses on the ward, even ranging to junior doctor, etc. So everybody have the role to play. It sounds complicated, but if you really break it down, I think day by day and also list by list, it really depending on what you do before, during, and after operations. So let's make some sense out of it if we can. So on the guideline that we listed out, I think preoperative education is very important. Patients' expectation on when they should be going home and how do you optimize patients' clinical conditions, including diabetic control, and also prophylactic antibiotics, etc., and no active using of bowel prep, all these other little things that colorectal surgery has now progressed, we can use it. And for us particularly is preoperative nutrition, and because we also put patients on Optifast before the surgery, which supposedly will minimize or make our operation earlier. So we got to be really in tune with patients' nutrition and preparation for surgery, and also treat the obstructive sleep apnea and also the cardiac problem before the operations. And I think another important thing is that during the operations, surgery itself, of course, nowadays most bariatric operation is laparoscopic, but our anesthetists are actually very important. There are actually core temperature management. In fact, it's very important that we learn from our colorectal colleague. Some of the surgery can be quite short, but some of the surgery can be challenging. And having patients on long time on operating table, which is going to be cooler and also ventilation wise to reduce the risk of COVID, we have to be very accurate in managing the temperature. And there's actually also talk about drains and etc. as well, which we don't routinely using it. And during the operations, of course, antibiotics and also thromboprophylaxis, because one of the major complications for any form of bariatric surgery is DVT and pulmonary emboli afterwards. And also managing of fluid is important as well. So this is only part of it. I'm coming back to this picture all the time because these are the most important thing that we should utilize for the patient after the surgery, including early mobilizations. And I think when you try to maintain the temperature, the reason why it's important is that if your patient is not in adequate temperature environment, it affects coagulation cascade, it affects the oxygenations, and the whole physiology of the patients will change. And that's been documented a lot in prolonged colorectal operations. And even if you have a minor deviation, such as 5 degrees of temperature difference, they've been able to prove that with complex colorectal surgery, the surgical site infections rate will probably be a 10% difference, which is quite a huge one, especially talking about us dealing with patients who are morbidly obese and also often with diabetes as well. So, and if we most of the surgery, sometimes not every surgery will go well, or if you have to deal with the complication, which I guess a lot of the colorectal presentations, such as perforated Hartmann's or procedure contaminated abdominal wall infections, it's been proven to know that if you have to go that way, you in fact have to throw everything in this patient, such as using ioban to suppress the antibiotic, so to suppress the bacteria that will get into the wound, because we all know that one major wound infection and laparotomy will at least cost the hospital or the patients approximately $100,000. And that will offset a lot of the costs that you're going to save from laparoscopic surgery and discharging patients. So it's something that you need to be aware. And if you're dealing with wound, then certainly things like Provena or negative pressure wound dressing has also been proven to be an important way to actually reduce long-term complications. let's not drawn on too much. But in fact, even if you're planning or electively to do any surgery for open operations in some of the cases, then besides assessing patients' risk, these are the things that we should manage. And orthopedic surgery and colorectal has been widely adapted already. So why aren't we doing that? I think the main thing is that there are a lot of guidelines that are being written already. It might sound repetitive, but because it's so complicated, I might try to see if I can make some sense out of it. The ERS Society is already hammering us on stopping smoking before the surgery. So we tend to see smokers have more long-term or short-term complications, and also suggesting for us to preoperative weight loss and also glucose management. And some of the medication, the anesthetic used are mainly to help us to deal with their nausea and vomiting to make sure that they can go through the surgery quicker um, and with more comfortable and tolerating more fluid orally quick in a rapid fashion so they can go home early. And during the operations, I guess laparoscopic surgery is something that we usually advocating on. So I guess you have to optimize the environment for your operating field to make sure that surgery is straightforward. And I think post-operatively, we really need to rely a lot on our anesthetic colleague and ourselves to actually looking at using multimodal treatments to avoid narcotic so that they don't get too nauseous and they can actually drink fluid earlier without vomiting and very quickly replace nutritional deficiency if we can identify them. So these slides are pretty repetitive. I might actually just skip that, but essentially these are another way to look at what I show you on the bar chart because this might look complicated, but and even if you look at Canadian consensus that they break down to points, I sometimes still prefer seeing the bar chart, which is more easily to be visualized. In our hospital, in fact, when we first started adapting it about 12 years ago, we very clearly noticed the shortened length of stay because in our hospital, we routinely dealing with more than about 1,500 patients per year. And any shortened length of stay will means that hospital allow us to have the ability to actually deal with more patients. That's saving resources and also enhancing patient experience. We're able to shorten our length of stay from typically 4 or 5 days to now down to 2 days. And that's even application for bypass and sleeve surgery. These are some old data as well. But I think the new data that we collected is pretty much the same. To make it simple, I think since it's so complicated, why don't I just suggest about a few things that at least you can chew on it. The 3 year that I think that is important for surgery beforehand is endurance. The patient need to be told that they need to endure and also put up with Optifast for a few weeks. They need to eradicate the bad habits such as smoking, helicobacters, etc. And education is the key in terms of our nursing staff and allied health and our dietitians to make sure that they understand the process and to what they're expecting. Because if they're expecting or they've been told that they need to walk straight after surgery, they will do it. Not only just told by ward staff when they are having an anesthetic afterwards, but it's best to be telling them beforehand. And during the operation, I think a lot of the times airway issue is the things that make a difference between a good and bad operation. So you should routinely have availability of video laryngoscope. In terms of anesthetic protocol, I think it's important to know that they need to use Sugammadex, for example, to wake the patient up early so they don't spend a lot of time on operating table. And after operation, I think it's important to establish oral fluid and very quickly to allow them to have adequate fluid intake to be able to be discharged and avoid oral narcotic operation to reduce the amount of nausea and vomiting. Get them out early and get them walking. That's important as well. So the 3O. I think the main thing about that is after we've done that, there's a lot of meta-analysis that has been published. And most of the meta-analysis that we find are built on what protocol that been taken for ERAS from different places. And particularly, I think emphasis has been put on by different countries, different way on different and on their minor different enhancements. But mostly, if you look at all the published studies on meta-analysis, they seems to agree on the fact that to avoid post-operative vomiting and to actually use less narcotic, and it's actually quite safe even to send patient home early once their pain is under control, and to pick up complication early, because the earlier you can pick up any deviations from the protocol driven discharge or the protocol driven recovery, that you can minimize the complication that patients will face. Same thing about ERAS in terms of bariatric operation is it's been confirmed that they can reduce the length of stay from 4 or 5 days to about 2 days, to the fact that nowadays there are people thinking of sending patient home the day after surgery as well. That might be pushing the envelope, and some of the surgeons might not be comfortable with that, and it may not be achievable in all the patients, but in all means, I think they should try. So I guess I might be running out of time, and so I prepare a lot of the data, but I think that if anyone want further articles that are listed, I'm sure they can either look it up or feel free to send me an email. I can get them some further information regarding of what we should be using. And to implement it, in fact, from cost point of view, it's been proven that if we're able to do that, the hospital can save almost $800,000 a year in some of the setting, even just minor changes. And I think this is a similar way to say that, this is a method that we can use to tell our payers that this is a good way, and in fact it's money well spent if we need to use certain instrument or equipment that will cost the hospital more money. So my little conclusion is that bariatric surgery is beneficial in producing long-term health and economic saving, and ERAS definitely is a must in any bariatric units that considering to doing more higher volume of surgery, and you can apply that to your other surgery as well. And mainly is careful navigation of patients and staff safety during the startup period time, because we don't want any breach of protocol to infect our patients or infect our staff. And maintaining normothermia and dealing with wound problem is really important, and we underestimate the power of that. These are the
Thank you, Ken, for a wonderful presentation. So I really think that the ELAS is a must in our practice. And but to tell the truth, in Japan, not many bariatric surgeons accept ELAS. For example, only a few institutes can have discharge within 3 days after surgery. Almost every university wants to keep the patient for 5 to 7 days after surgery. So how about in Australia? Are they acceptable?
Yeah, a lot of the high volume centers nowadays are standard for 2 days to 3 days discharge, to the fact that I think, basically patients are anticipating that. And some patients, as you know, especially for countries that are self-paying, if they're actually being told that your surgery, provided all the surgery went well and it's not revisional surgery, it's simple, straightforward surgery, the expectation should be almost 2 days stay. Any extra stay they may have to pay. So then the patient usually go home. So there's a little bit of a issue. So it's hard, but the evidence is there. Kazu is very strong, and it's not like we don't care and just send the patient out. But that's why you have to educate your staff to have phone call to make sure that they're okay. And there probably will be some patient that you need to bring them back for hydrations, but I think the numbers are far less once they establish oral fluid. And I think your partnership with the anesthetic is very important. And as you've seen from your report, a lot of other surgeons in other countries are doing not only just bariatric surgery. They can use this protocol for the other operation, like day-only hernia, day-only gallbladder surgery, and even colorectal surgery. 2-3 days they go home. Prostatectomy used to be 5 days in hospital. Now the next day they go home with a catheter. So I think we have come a long way along. So we have a lot of surgery to catch up. So hopefully our colleague can utilize this, even though it seems a little bit repetitive. I might not have my thought together, but we're trying to make some. May have to close these sessions, and I think we'll leave some time for our next best paper, Kazu.
Yes, that's right. I'd like to close the session. Thank you, Ken Loi and 3M for sponsoring this session.